Thank you. Thank you for a nice introduction. Good afternoon, everyone here in the auditorium as well as you're connected online. I'm great, it's great to be here. It's an honor to be invited to such a wonderful meeting. Here's my disclosure slides. Looking at this slide, we see the wonderful story, fascinating story of HIV infection lasting for 4 decades already. Right now, we are able to provide to our patients effective therapy, improving their quality of life, prolonging the life expectancy. It's right now comparable with the HIV uninfected population. But we don't have to forget on those who are in threat of acquiring HIV infection, and therefore we are speaking about the prevention. We have many effective tools in terms of prevention, like treatment as prevention, post-exposure prophylaxis, and intervention focusing on improving the disease awareness among the people in risk. But one of the most fascinating field within the prevention issue is the pre-exposure prophylaxis, and I was focused on that, or whole this session is focused on pre-exposure prophylaxis. I'm trying within my presentation to choose for you and share with you some data I found interesting and that were published in a recent times. First molecule I want to start with is a cabotegravir. I will not read the company abbreviation with all those numbers, but cabotegravir is a second-generation strength transfer inhibitor. It's right now indicated for treatment and prevention as well in the version of long-acting, so it's intramuscular. For therapy, it was launched for the very first time in 2020. The first country where it was launched was Canada, and right now the other countries, even within the Europe, are starting to implementing the cabotegravir into the therapy. Last year in the EACTS of 2021, we've heard a nice presentation from one of our Canadian colleagues presenting the first experience with using cabotegravir in a clinical practice. As PrEP was launched already in 2021, but only in the United States, as you can see at the map, but other countries like Brazil, Australia, and some African countries like South Africa, Zimbabwe, Botswana are planning to use, and they ask their local agencies to get approved cabotegravir for use as a PrEP. The crucial and the most important studies within the use of cabotegravir as a PrEP is HPTN 8083 and HPTN 08084. HPTN 083 is a randomized controlled trial of people in risk who are MSM or transgender women, as conducted at 43 sites in seven countries, and the whole cohort is huge. I will not go to in details. You can see it in a slide. You can see here the design of a study. So it's randomized, controlled, double-blinded study with 2 arms. One using daily oral TDF FTC PrEP, and the second arm is using the intramuscular cabotegravir applied every 2 months. There is a leading phase. There's leading phase at the very beginning for 5 weeks, and then for 3 years the standard phase of a study. During the time, based on the preliminary results of a study and due to the superiority of the cabotegravir, the original design was changed, and the arm with oral daily PrEP was changed. But after the blinded part, there was also optional unblinded part, and the results from that phase of a study was presented this year by Rafael Landowitz at Croyd, and I will show you some of those details. These are the efficacy data. So HIV incidence is it's a major point of the results. In yellow, you can see there the cabotegravir results. So altogether, the blinded and unblinded phase, they found 25 new infections on the side of cabotegravir and 72 infection in an arm of TDF-FTC, now oral daily PrEP. So combined risk was 0.33, which was quite low, and we can see here the the superior, the better results of a cabotegravir. At the bottom, you can see there a time scale. The major problem or concerns, looking at the data from the HPTN 0.3, are those patients. There are not many, there are few. We can see here 5 patients, and in total there are 7, where the HIV infection was diagnosed, but there was no, problems within the scheme of, timing of application, etc. So those examples of HIV infection are so-called unexplained. So there must be a following analysis made to helping us with the explanation of those problems. Early and during this day, we're speaking about the cabotegravir even in a treatment of HIV-infected patient, but the problems and the concern could be very similar. It's a new molecule, and we have to know more data about this molecule. What about the drug adherence data in HPT 083? On the left-hand side, we can see there the TDF-FTC measurements, not the adherence declared by the patient, but the exact data coming from dry blood spots or plasma level of tenofovir. So we can see here in the first 2 bars data from a blinded phase. In the second part, 2 bars in the middle, the unblinded phase. We can see there a drop in the adherence. It's predictable. And the first 2 bars showing the data from, let's say, post-combined period, post-hoc analysis. On the right-hand side, the cabotegravir data. So we can see here, it's understandable, the very high rate of drug adherence, a mild drop in a part of unblinded part, and the post-hoc analysis combine those two bars and 2 data. HPTN 0.4 has a similar design, has been conducted in Africa in some countries in cisgender women. There were also 2 groups, controlled, randomized. One of the arm is using the cabotegravir and placebo of a TDF-FTC, and then the second group is using the cabotegravir and placebo as a TDF-FTC. The timing was comparable, so the 5 weeks of lead-in phase, 3.5 years of a blinded period of a study, and the step 3, 48 weeks of open label phase, where all the participants, they were using the TDF-FTC, in unblinded phase. What about the primary outcomes and the HIV new cases? So in arm of cabotegravir, only 4 cases. On the side of TDF-FTC, 36 cases of HIV infection. So HIV incidence was 0.2, comparing with 0.35 in a previous study, HPT 0.83. Looking at the similar, let's say, system of describing the cases, from those 4 cases in a cabotegravir arm, there were 2 without any delayed timing of application or non-adherence from the side of a patient. So they're so-called unexplained. There were 7 in a previous study and 2 in a 0.84. So we have to know more data. At the bottom, you can see their analysis of a TDF-FTC, newly acquired infections. Another molecule is a Dapivirine. It's a non-nuke I heard about Dapivirine for the first time already in 2004, but it was never applied into the clinical practice as a treatment. So right now it's available for the prevention only in a version of vaginal ring. The vaginal ring was approved by European Medical Agency in 2020, but it's not routinely available in Europe. What about the efficacy? We see here data from 2 randomized studies, Aspire and Dream. The cumulative or the effect is around 30%, but in a non-randomized study, we see the higher rate of efficacy around 50%, but it's incomparable with, for example, the standard one, TDF-FTC or other molecules. So it's some kind of complementary method to prevent the acquisition of HIV. One of the studies that were presented recently at CROI 2022 was the REACH study. It was also a randomized study with 2 arms, one part using a Dapivirine ring, and second for 6 months, and second arm used the oral PrEP. And after the first phase, after the first 6 months, they switched, so they used the opposite product. So those who were using Dapivirine in the first phase, they used the oral PrEP, and in a second part, and vice versa. And it was called crossover period, and then followed by choice. They call it choice period, when the female patient, they can use what they want, what they choose. That's what I want to show you. On the right-hand side, there is the graph showing that 67%, which is 2/3 of those patients, approximately 250 female patients, during the choice phase, they've choose the ring, because it was more feasible, more comfortable for them. All the patients, they get the experiment with both versions, with tablets and with the ring. So therefore, I want to share with you such a result. The third and the final molecule I want to speak about is islatravir, MK-8951. It's a nucleoside reverse transcriptase translocation inhibitor, or NRTTI. It's a new molecule that was tested for the treatment and prevention. It has never entered the routine clinical practice. It has some of special features, like very long half-life, approximately 190 hours, and therefore is very, like a good candidate for using in a PrEP therapy. It's available in 2 forms: 1 monthly oral tablet, and subdermal implant, which is very tiny. You probably can't see it because it's white, same as the picture. I want to share with you another picture, another data presented at CROI last year. It was a modeling of application of that subdermal implant containing 56 milligrams of islatravir for 12 weeks. And there was a modeling, you can see there on a slide, that using that implants for longer period, it can be sufficient to prevent the patient using it as a PrEP for a year or even longer, which is very suggesting and promising. What about safety data using the subdermal implant? You can see there in a left-hand side column the patient with placebo, and in a second, third, and the fourth column the patient using islatravir as a subdermal implant. It's a small number of patients with a probably high proportion of side effects as erythema, pruritus in duration. But if you look at the placebo data, you can see there like quite consistent and similar data caused probably by the subdermal implant itself, but not by the islatravir as an effective agent. Last study I want to mention is MK8591 016 protocol, which is the use of islatravir as a PrEP. Recently they were presented data from week 24. Included there were patients with aged 18 to 65 years of age. They were seronegative for HIV, and they were in low risk of HIV. The cohort consists of 50 to 250 patients, one arm using islatravir 60 milligram, second arm using islatravir for 120 milligrams, and third arm of 50 patients using placebo. And recently there were presented data of weight change or weight gain. You can see here at the bottom. So there is almost no change between placebo and the smaller dosage of islatravir, but we can see there some mild increase in weight in those using 100 to 120 milligrams of islatravir. At the upper part, we see the DEXA results, DEXA scans looking at the fat distribution and bone mineral density. So on the left-hand side, the peripheral fat and trunk fat, we see no increase in that aspect in terms of islatravir 60 milligram in comparison with the placebo, but some increase in terms of those using 120 milligrams of islatravir, but no significant changes within the bone mineral density in total hip and lumbar spine. Before I will finish my presentation, I would like to say that PrEP is a wonderful tool we have. It was not easy to implement it in some part of Europe, including my country. I had a chance to be one of the first PrEP advocates within Czech Republic. We succeed. We're using TDF-FTC as the standard PrEP agent, but I'm looking forward any new data coming from the science that will come and step into the clinical practice in the future. So I thank you for attention.